Welcome everybody to Grand Rounds for January 2024. Just answering the one question that was in the chat, and yes, it is approved for direct access as well. So today we have two presenters talking about a pediatric rehabilitation perspective on amplified musculoskeletal pain syndrome, or AMPS. We have Dr. Courtney Bucher, who strives to afford an enriching life experience through empowering children's movement abilities. She received her bachelor's degree in health science from Quinnipiac University before continuing to receive her doctor of physical therapy from Drexel University. She completed her pediatric physical therapy training at Good Shepherd Rehabilitation Network and Drexel University's pediatric residency, and is board certified in pediatric physical therapy. Dr. Bucher's love for family-centered care and innovation drives successful outcomes. She has diverse clinical experience in which she concurrently works as a neonatal intensive care unit and pediatric inpatient rehabilitation, as well as a pediatric outpatient rehabilitation office. We also have Ms. Jessica Zelenak, who is passionate about providing affirming evidence-based care to children of all abilities and backgrounds and their families. She earned a bachelor's of science in health science and with a minor in psychology, followed by a master's of science degree in occupational therapy from the University of Scranton in Scranton, Pennsylvania. Ms. Zelenak has advanced trainings in chronic pain techniques, sensory processing, interoception awareness, reflex integration, vision, play, and executive functioning. She's also certified in the SOS approach to feeding. She strives to make each session unique and fun for her clients while helping them to regain or develop new skills needed to participate in occupations that are meaningful to them. So if you haven't already signed in, make sure you use this QR code really quickly before I change the slide, or use the code on the left of the screen. And if you miss this slide, you can always go to the attachment that's in the meeting invite. The credit information that we have, it's to attain a comprehensive understanding of AMPS and provide rehabilitation intervention strategies. And this is targeted to all providers. This is our designation statement, and the planners and presenters have nothing to disclose. So I will now turn it over to Ms. Zelenak and Dr. Bucher.
Thank you. So first we're going to start with our learning objectives for today. So first we're going to define amplified muscular pain syndrome, or AMPS, and understand a patient's clinical presentation. We're going to understand what medical diagnoses coincide with AMPS. We're going to perform an initial evaluation with reliable and valid tests and measures. We're going to synthesize the best practice for rehabilitation interventions for patients with AMPS. And then finally, we will formulate appropriate goals, monitor progress, and means for discharge from rehab services with a focus on PT and OT. All right, so we're going to jump into what AMPS is. Amplified muscular pain syndrome is a term that encompasses the spectrum of manifestations of chronic pediatric musculoskeletal pain. The common thread underlying these different subtypes is central and/or peripheral sensory pain amplification, hence the name AMPS. AMPS is a spectrum of chronic, non-inflammatory pediatric musculoskeletal pain, and these children have real pain. They're not exaggerating it. Their body just tends to amplify that pain signal. AMPS tends to be the umbrella term. So it can also encompass other diagnoses: pediatric fibromyalgia, chronic regional pain syndrome, or CRPS, reflex sympathetic dystrophy, or RSD, reflex neurovascular dystrophy, RND. We will be using the term AMPS throughout our presentation because it's a really good descriptor of the pain that these kids feel. It's definitely that amplified pain signal. And we also want to differentiate between like some of the more adult diagnoses, RSD, CRPS, because the presentation is very different. So AMPS, the pain presentation, is described as a magnified and amplified pain in body parts lasting greater than 3 months. It can start in one body part and expand to additional body parts. It can present as a constant extreme pain flare or intermittent pain attacks followed by periods of no pain in which the child is in remission. And it's very important to understand that the pain is very real and not just made up or inside their heads. For individuals who are neurodiverse, it may be challenging for them to communicate the pain that they are receiving. And the pain that the person is feeling is also often amplified and would be more exaggerated than what we would clinically expect in response to an injury or sensory stimuli. So sometimes the amount of noxious stimuli doesn't correlate with the degree of pain that the child is reporting or demonstrating. So along with the amplified pain symptoms, there's other medical symptoms that we currently see that go along with the condition. So headaches and migraines. It's very common for a child to report abdominal pain or irritable bowel syndrome, difficulty sleeping, skin changes, such as temperature changes, or their skin may appear cold, clammy, color changes like their skin's purple, blue, or gray, rashes. Allodynia, this is when pain from stimuli that shouldn't be perceived as painful is, like clothing on your arm or brushing of a blanket results in severe pain. Weight loss, hyperalgesia, so increased pain due to neurobiological alterations in response to exercise, decreased strength and endurance. Studies have shown that children with AMPS are more sedentary and deconditioned compared to age-matched peers. They often tend to have more guarded movements with co-contractions, and as a result, some of them even require use of ambulatory devices. So they kind of regress and they may need, say, like a walker to help them walk. It can also result in deficits with executive functioning, so decreased working memory or cognitive flexibility. It's also important to know a lot of the psychological symptoms that we see that coincide with AMPS. So a lot of children have anxiety, depression, obsessive compulsive disorder, or suicidal ideations. So in addition to the medical symptoms, there's also a lot of functional implications. So the children and teens diagnosed with AMPS tend to participate less in a variety of activities, including the ones that they really enjoy, sports, music, arts, whatever it might be. They tend to not be able to make it through a full day of school. So they're either coming to school late, they're leaving early, and that's happening, over a course of the week, they might be missing a lot of school. Over a course of the semester, they're really missing a lot of school. The pain is preventing them from participating in time with their friends. They're not socializing as much. They tend to just be more sedentary and prefer to, lay around or not participate because the pain is so much. In addition, some of the researchers have found that there's some specific characteristics, like personal characteristics and family characteristics that go along with the AMPS diagnosis. So from a personal perspective, AMPS patients tend to be, mature beyond years. They excel at school and extracurricular activities. They tend to have that perfectionistic type of personality and people pleaser. In addition, their families sometimes are a little more, we call like a helicopter parent. They tend to speak for the child or the teen, and they'll look to mom and dad to talk for them. Sometimes they can have a lot of other family members with pain, which we would consider like a pain household. Maybe grandma has pain or mom and dad have pain, and they're observing how they are responding to their pain, and they might be learning from that or not learning the best coping mechanisms. And finally, understandably, parents are, concerned and worry about their child's pain. So they can start to go to the worst place, or we call it catastrophizing. If they're catastrophizing too much, they will say like, no, you can't go do that with your friends because you're going to be in pain. So then it's preventing them from participating in activities they enjoy.
So AMPS is either a primary or secondary pain condition. Often there's such a subjective report, again, of this amplified chronic pain in one or more body part. And physical examination often results in no abnormalities. And when medical tests are done, there's no abnormalities with the blood work, MRI, or x-rays. It can be a secondary pain condition to juvenile idiopathic arthritis, systemic lupus, or even Ehlers-Danlos syndrome. So the cause of AMPS is really unknown. There's been some proposed reasons or underlying factors. One could be that the child had some form of an acute injury in the past that kind of resulted in this flare-up and exacerbated amplified pain, such as a broken bone. Many children who report an injury, they often report their said injury with emotionally laden language, like, I was kicked by the meanest girl at school. Less frequently, there could be some sort of a previous illness like mono, the flu, or COVID. They could be genetically predisposed. It could commonly occur with other conditions like we mentioned. And it's important to note that when some kids have like anxiety or depression, the neural circuitry and neurotransmitters that are involved with anxiety and depression commonly overlap with having AMPS. So that's why we see those things coincide.
So the prevalence of AMPS, it's not a very common diagnosis. However, we're seeing more and more of it. It occurs in about 2 to 6% of the pediatric population. Females tend to be more affected in a 4-to-1 ratio. The most common age is between 13 and 15. However, there are some kids that we're seeing that are even younger than that. And pain tends to start in the lower extremity, which is different than adults. Their pain would tend to start in the upper extremity. The prognosis, there's many mixed reports again. It's kind of a mystery with some of this. Earlier studies reported that 90% of children were pain-free and functional after 5 years. But more recent studies, after 2 years, 70% of children were not meeting that diagnostic criteria anymore, which is great. However, 50 to 70% of adolescents with AMPS continue to have this physical and psychosocial symptoms into adulthood. Now, the symptoms may have been less, but they're still having them. That pain catastrophizing and the fear of movement lead to obviously a poorer prognosis. And an AMPS flare can occur. So you could have AMPS be in a remission and kind of occur again. And that usually occurs in the first 6 months following the initial diagnosis.
All right, so now we're just going to do a quick neuroanatomy review so we have a better understanding about what's happening in these children and adolescents who are diagnosed with AMPS. So first, let's just review what a typical pain response looks like. So in the periphery, there's some sort of stimuli or injury, and the pain signal is sent up the spinal cord and to the brain. So the pain signals that are initiated in the periphery are received through nociceptive receptors within the tissue. Either the stimuli is mechanical, chemical, or thermal. And the sensory information travels up through the A delta or C fibers, is synapses on the dorsal horn of the spinal cord, and the pain is processed within the central nervous system. This is where it's processed to the body as a threat. Now, even though the body may process something as pain, it does not actually always correlate with tissue damage. There's actually over 9 key areas within the brain that process pain. And this also explains why chronic pain coincides with the other compromised functionings that we've been talking about, like impaired sleep or decreased cognition. There's this concept called the pain neuromatrix, and it's this term for the individualized brain pathways that process the perception of pain. And the neuromatrix is unique for each person and can be modulated with pain experiences. The central nervous system has several ways to inhibit incoming pain responses, so that way we can function. So one example is the release of endogenous opioids to inhibit incoming afferent information. So within the sensory cortex, there's the homunculus. This is the geographic mapping of the human body. And in individuals with chronic pain, the homunculus becomes smudged, enlarged, and there's decreased localization of where the pain exactly is occurring in their body. So in children with central sensitization, there are changes in the structural and metabolic activity of the central nervous system. So the body interprets pain at a heightened level due to impaired pain modulation. So there's these neuroplastic changes that are happening. So some, to name a few, there's a decrease in the second order interneurons in the dorsal horn of the spinal cord. And this facilitates sensory information to continue to ascend towards the brain to process the pain. There's an increase in sensory fiber synapse in which pain becomes more global, and inappropriate sensory synapses also begin to occur on the contralateral side of the spinal cord. The third thing that can happen is, again, this decrease in endogenous mechanisms to inhibit the pain pathways. There's smudging of the sensory cortex homunculus. And lastly, there's often vasoconstriction of the neurovascular nerves, which causes blood flow to slow. And when this happens, there is a buildup of acid waste, which causes more pain.
Okay, so now that we reviewed what AMPS is, how the abnormal pain cycle works, let's start talking about evaluating and treating patients with AMPS. Ideally, we want to have an interdisciplinary team, just like most of the other diagnoses that we work with. That multimodal integrated approach works best. And that team could include physicians, physical therapists, occupational therapists, mental health providers, and obviously anyone else on their medical team. So the roles of each of these team members, the physician would be the one, obviously, to complete the physical exam, complete any medical tests, blood work, MRI, diagnose the AMPS ultimately, and then sometimes they would prescribe medications. From the research, we found that AMPS patients tend to not respond well with the medications. There's no real change, except for a vitamin C supplement that seems to help some. The physical therapist role would be to work on strength and endurance training, functional exercises. The OT's role would be to use meaningful occupations to heal the pain, developing physical, cognitive, psychosocial skills to participate in those daily occupations. And finally, the mental health provider would work on thoughts about and around pain, any global anxiety, depression, any other diagnoses that they have, some coping skills. And then some of the strategies they use are like cognitive behavioral therapy, exposure therapies. They would work on coping skills, and meditation or mindfulness might also be used. All right, so looking a little bit more at specifically outpatient PT and OT evaluating. So again, we're going to use a multidimensional assessment. We really want to look at the whole person, how that pain is affecting their whole life, not just focusing on the pain. We're going to first start with history, just like we do with most of our other patients. So our medical history, we're going to ask about all their current diagnoses related to pain, not related to pain, current and past specialists that they might be seeing, medical test completed results, did they have blood work, did they have an MRI to help rule out some other diagnoses, because that's how AMPS ultimately is diagnosed. Any mental health services, are they receiving any right now? Ideally, when we're doing treatment, especially in an outpatient setting, we really want to have a mental health provider on board, someone that patient really clicks with is really important. Some pain history, obviously, we want to know all about when it started, what maybe will have caused it, or when they noticed it started, any new stressors or life changes, any aggravating factors or things that might make it feel better, any previous pain diagnoses, did they have AMPS before or a different pain condition, have they participated in an inpatient program, a different outpatient program, have they gone through any of those other programs before? family history of a pain diagnosis, like I mentioned before about those pain households. Does anybody else in their life have significant pain that they might be associating with? And then finally, social history. How are they doing at school? Are they going to school? Are they missing a lot of school? What they're currently participating in extracurricular wise, any social activities, and any big changes to their family dynamics. Someone got married, someone got divorced, things like that. And as an OT, we would use all that information and talk with the client to figure out what are their meaningful occupations. What do they, what are they not able to do right now because of the pain, and what do they want to work towards so that they have that full occupational participation.
Okay, so now we're going to move on to some of the pain assessments that we use. Again, this is only done at the initial evaluation and reevaluation. We are not asking about this, every session. So we have the visual analog scale, or the 11-point numeric rating scale. This is good for children whom are around 6 years and older. And then we also have the FACES pain scale revised, where a child as young as 4 years of age can choose which face coincides with the pain level that they're experiencing. The tool that I would say I tend to use in some of the adolescents is the Pediatric Pain and Symptom Assessment tool. So it's a conjunction of the widespread pain index and the symptom severity scale. So the patient can demark where on their body they're feeling pain, and then they can also rate the intensity of the pain. And then they also score the severity of their symptoms. There's the 3 cardinal symptoms: fatigue, difficulty thinking or remembering, and then fatigue. And then they can also record other symptoms such as abdominal pain, depression, or headaches. So as for activity level outcome measures, I frequently find that I use the BOT. Again, this is good in children 6 to 21 years of age. So for some of those adolescents, it gives us a good idea of their gross and fine motor functioning. So it looks at fine motor control, fine motor integration, manual dexterity, bilateral coordination, balance, running speed and agility, upper limb coordination, and strength. And this also gives us norm reference data for age and sex matched peers, so we see how they kind of align with them. And then as for some cardiovascular testing, the Bruce treadmill test is always great. This is a maximal cardiovascular endurance test in which the subject is asked to walk or run to the point of exhaustion, and the speed and the incline begins to gradually increase. And then there's also some submaximal tests, which are the time 6-minute walk test and the time 3-minute walk test. So we can see how far the child can do a walking distance in a period of time to get an idea of their endurance. So then there's various participation level outcome measures that we look at. So one of them is the PROMIS, which is the Pediatric Pain Interference Scale. So this outcome measure was created for patients with chronic conditions as a self-report measure by the National Institute of Health. And it's an assessment which allows us to understand how their pain interferes with their social, cognitive, emotional, physical, and recreational well-being. So the individual gives their responses on a 5-point Likert scale. The scores range from 8 to 40, and a higher score reflects greater disability. The Functional Disability Index is also commonly used, and also commonly, you'll see this one used in research. This is a self-report outcome measure, and the child or adolescent reports their challenges to complete activities of daily living on a Likert scale. The score ranges from 0 to 60, and higher scores indicate a greater level of disability. The minimally important clinical difference for this is 7.8 points. This is the current gold standard measure in a lot of robust studies, and it demonstrates good reliability, validity, and responsiveness for children with juvenile fibromyalgia. And in case you wanted to kind of gauge where the child is in regards to readiness for, changing their behaviors and seeing if they're ready to engage in therapy, there's the Pain Stages of Change questionnaire, and the score correlates to the readiness for a cycle of behavior change. So pre-contemplation, contemplation, and maintenance.
Some other ones from an OT perspective, the Canadian Occupational Performance Measure, the COPM, could be utilized in kids over 8 to identify a client's self-perception of performance in everyday activities. The role evaluation of activities of life, or the REAL, is another great one that looks at ADL and IADL performance, and that's for children between the ages of 2 and 18. And finally, sensory profiles, that gives us a good idea of what their sensory preferences might be as we go through treatment. So in addition, another thing to look at and measure would be the caregiver's perspective of everything. Again, like I had said, it's not just the AMPS patient, we're focusing on kind of their whole being in their life. And so that includes obviously their family. So the pain catastrophizing scale, there's a child and a parent version. That's for children 8 to 17 years old. And it assesses, again, that like pain catastrophizing. The higher the score, the more they're catastrophizing. And finally, the adult response to children's symptoms, or the ARCS, is another assessment that can look at parents' perception of their child's pain. So once we do all of these assessments, once we gather all of our history, we have a pretty good idea of what this patient, what their pain level is, what they're missing out on because of their pain, we're obviously going to work and make our own goals. So as for PT and OT, our collective goal would obviously be to return them back to their functional status wherever they were before, physically and psychosocially. Our goal is not to eliminate the pain. If we do eliminate, that's great, but that's not our goal. Our main goal is to get them to a pain level that they can continue to participate in these activities that are meaningful to them. Okay. So focusing a little bit more on treatment from an OT and PT perspective in the outpatient setting. Just some general guidelines that apply to both disciplines. Individual treatment plans are vital. Just like every other client that we treat, we need to make sure our plans are, related to them and what they need to work on to gain more functionality. The education about AMPS is essential. StopChildhoodPain.org is a great free resource. They have a lot of articles, they have a lot of videos out there for parents and children to be able to go and watch so that they understand this diagnosis along to what we would be educating throughout the sessions. We really need to focus on what AMPS is, how the diagnosis, how that pain cycle works, why we're doing intense exercises and these desensitization techniques in order to break that pain cycle. If we don't educate on all of that, then they're going to be like, why are we doing all this? And you're not going to see the outcome that you need. We want to decrease their pain. If they're not buying it, it's not going to help. Another key point is during our treatment sessions, we don't talk about their pain. We know that they are in pain. They're in constant pain. We understand that. The goal is to keep pushing through to break that pain cycle. If we harp on it too much, then they're just going to keep flooding it and they're going to be like, I'm in pain constantly. So that's not going to help. We also have the parents stay out of sessions. At an initial eval, at a progress note, something like that, they can come back, but we try to keep them out for a variety of reasons. We really want that patient to take charge of their health. We want them to work on their self-advocacy skills. Sometimes parents unintentionally might undermine us. They'd be like, oh no, they can't do that activity. They're in too much pain. So we try to take that piece out because we really want to work obviously on getting them back to that level. Building a strong therapeutic relationship grounded in trust is essential. So if our patient, if we say, oh, your pain's not real, that's not going to help the situation. So we need to make sure we're really building that strong rapport and that relationship with them so that they feel comfortable and that they trust us in what we're doing. Again, it's really important to tell them we understand your pain is real. We know that you're having all of this pain so that they feel trusted and validated. And movement is essential for both, OT treatment and PT treatment. We need to keep doing these movements to reset those nerve pathways. All right, so frequency in outpatient, we tend to do either 2 to 3 times a week of PT for 8 to 12 weeks. And then we couple that with either 1 or 2 times a week of OT for the same amount of time. The sessions tend to be about 45 minutes. So if we can, get the schedule to work, we try to do one right after the other. So it's a big total of 90 minutes, which will help obviously with that endurance and strength training too. Majority of the sessions would probably be on the land, but if you have like an aquatic option, you can take them in the pool. That's great, obviously, for the strength and endurance things, but also for the desensitization piece.
So it's important that families and children understand that exercise is good. It assists with stimulating the brain regions that are responsible in the descending inhibitory pain pathways. So it helps to kind of calm down some of those pain pathways and improve pain modulation. Functional MRI studies have demonstrated that consistent exercise can reduce pain perception in individuals with fibromyalgia through these neurological changes. In one specific study, Black and Zuck proposed a new exercise approach in which they termed fibromyalgia integrative training as a tailored and progressive exercise program. So they paired cognitive behavioral therapy with what they called neuromuscular training. So they chose functional movements such as a squat, push-up, and they progressed it from isometric, concentric, eccentric, and then they did the full functional movement. And encourage activity. The American Pain Society recommends at least 30 minutes of moderate to vigorous activity 2 to 3 times a week. Resistance exercise has been shown to improve physical activity and aerobic exercise to reduce pain levels. And movement is helpful and not harmful in the child's recovery. And frequency really matters. As we said, we aim for more intensive therapy with having psychology on board. In a cohort of children with fibromyalgia treated with intensive rehab, they demonstrate improvements on standardized testing. So there were 64 children. They had a median age of around 16 years of age. Prior to admission for intensive rehab, all children were taken off of their pain relieving medications. And some of the interventions was this intensive rehab that focused on return to previous level of functioning. Each child received one-on-one therapy for 5 to 6 hours a day. Some examples of some of the aerobic exercises that were done were cycling, treadmill, elliptical. Some of the strengthening activities were anything from functional movements to timed activities for animal walks. This also involves some desensitization activities. And again, the philosophy was that children will get back to their level of functioning, not necessarily eliminate pain. And children did better, showed improvements on the BOT2, and they sustained these improvements at 1-year follow-up. There were also significant improvements for endurance on the Bruce treadmill test. On the pain stages of change questionnaire, the child's readiness to change significantly improved. And for their participation, to get an idea if that improved on the pediatric quality of life inventory, there were also significant improvements.
Okay, so some treatment strategies that can be used in helping with AMPS patients. Obviously, we're going to use meaningful occupations as our main source. If they're into sports, playing soccer in your session, if they like arts and crafts, doing adult coloring pages, they could be sitting on a yoga ball, they could be kneeling on a wiggle mat, they could be doing a crafts kit of some sort. If they're interested in music, having them bring in like a musical instrument during their sessions and using that. Video games, they might be playing and enjoy certain ones, so we can integrate those in. Cooking, making cookies, or even like ice cream sundaes are always fun to do too. We also would focus on implementing better routines, really focusing on that sleep routine, focusing on hydration, diet, and stress relief, adding those components into their daily life and routine, so we can, help them through their normal activities. Working on self-advocacy versus relying on family members to kind of communicate for them is really important. Again, education, can't stress that enough. And lastly, like therapeutic use of self, again, building that strong relationship with, with us and with them. Some more obstacle courses, they're unlimited, they're great. Yoga, things like Cosmic Kids Yoga online, or making up your own yoga story to get them not only for the physical component, but also like that deep meditation and relaxation. Therapy exercises, hiding pieces in there, working on the hand strength, giving them some good proprioception through their hands for that. Desensitization activities. So Courtney mentioned before, rubbing a towel on the part that is causing them the most pain. You could use like a vibration tool. You could also there's like a couple videos online from CHOP. They have this whole program, so you can use that as part of your session or as part of your home exercise program to have them continue to do that at home. Board games, escape rooms, puzzles, cognitive activities like that are fun and engaging. You could add adding a physical component into it are great tools to use too. Mindfulness, meditation, there's some great ones online, Go Noodle, and some other ones for younger kids. Along with that is interoception awareness. Kelly Mahler is another occupational therapist, and she has this amazing program out there. And it helps, we work with the kids to become more aware of body feelings inside, body signals. And then, using those to determine emotions or body states, and kind of like if we need to do anything to make ourselves feel better, to self-regulate. And the importance of that would be to not think about the pain then. So we're thinking about those other body signals versus just the pain. Because sometimes the pain will kind of take over and we miss those other signals. Graded motor imagery is another one, and there's some really cool activities out there like for virtual reality too. Home exercise programs, just like all of our other clients, these are essential, and particularly in AMPS, we see them a lot during the week, but the other days that we don't see them, they also need to be continuing to participate in this physical activity and all of these other strategies that we're giving them.
So the goal is always that the child is discharged from outpatient rehab and they've met their goals and they have demonstrated improved level of functioning. But in order to promote long-term adherence, to encourage physical activity, studies show that there is actually poor long-term adherence with traditional exercise programs. So exercise programs that tend to be self-paced and are at a lower intensity have shown to have improved long-term adherence. So for example, yoga or Tai Chi.
So we would consider a kid to fail an outpatient service or an outpatient therapy program if they had little or no progress in about a 12-week program. That means that they still have tons of pain, they're not returning back to their daily activities. So the next step might be to either try the program again, which sometimes helps, but not usually. Sometimes they will recommend an inpatient program. So an inpatient program would be more of you're staying at the hospital for a couple of weeks, 1 to 4 weeks. You're getting 5 hours of PT and OT every day. You can also participate in psychotherapy as needed, music and art therapy too. We're lucky to have a couple of programs close by. So when we do get those AMPS patients that may have failed the outpatient program, we can, refer them out, or the doctor would refer them out to CHOP is nearby, Children's Specialized Hospital in New Jersey, and also the other CHOP in Pittsburgh. All right, so we're going to go through a case study of a patient with AMPS named Mary.
So Jess and I worked with Mary at the outpatient level. She was an 8-year-old female. The rheumatologist diagnosed her with AMPS, again, after doing a workup and finding no significant findings. She had unspecified joint pain and global musculoskeletal pain. She also had ODD, oppositional defiancy disorder, and adjustment disorder diagnoses. She was seeing a counselor at school, but her counselor was on maternity leave during the evaluation and then returned halfway through for treatment to help with the program. There was a significant social history here. So mom disclosed that she lived with chronic pain and anxiety for years. There was increased family stress over the past 2 years in which the father had been out of work. So there was lots of fighting within the household, extra stress on the family, and the younger brother also reported feelings of stress as well. She started to complain of various pain throughout her body for 2 years following days of fun outdoor, and this happened around COVID. She reported mild skin changes such as irritation or rashes on the legs, and she had a decreased interest in physical activities in which she would rather read. She really did like to read or play on her tablet. And there were periods of time where she was not attending school regularly. So at the initial evaluation, she had 10 out of 10 pain that she's experienced recently, but 4 out of 10 at eval. She had impaired balance. With walking, she had very guarded movements. She also actually displayed like this shuffling pattern where she had decreased push-off. She had decreased fluidity with some of her fundamental motor abilities, such as jumping, hopping, and skipping. She had global weakness throughout. She also had impaired core strength on the timed 30-second abdominal crunch, and she also had below average endurance on the timed 3-minute walk test. So she was seen for physical therapy 3 times a week with the home exercise program. And some of what her interventions look like is we focus on some cardiovascular endurance, such as the treadmill. We started with walking, and then it was eventually progressed to intervals of walking and jogging, and then just straight jogging and running, which was great. Seated scooter activities or biking. Self-paced fundamental movement activities like skipping, jumping, hopping, or running across the gym up to 50 feet. And then some global strengthening, so upper extremity strengthening, lower extremity, and core. So some of the goals that I wrote, just to give you an idea. So for some of the short-term goals to be achieved within 6 weeks, I said that she would score age appropriate on the 3-minute walk test to display improved age appropriate endurance, that she would demonstrate the ability to perform whatever the score was for the age matched norm for the 30-second sit-up test. And then for the long-term goal, that she would be able to participate in 30 minutes of continuous play activities outside with friends without reporting fatigue or for improved endurance. That she would demonstrate improved growth strength with increased muscle grade to 4 out of 5 globally for improved functioning, and then that the patient and family would be independent and compliant with the home exercise program for that carryover into her natural environment.
So in addition to her pain, she also had some difficulty regulating her emotions at times. Mom said she would get really frustrated. She had a hard time just, deciphering between her body signals. So had some difficulty with interoception awareness. She couldn't always identify what emotion she was feeling. Sensory processing wise, she was a somewhat picky eater. She had more sensitivities to clothing and stuff when she was younger. She did have that mild rash on occasion on her lower extremities. Motor skills, like Courtney just said, she had decreased core strength. She had difficulty motor planning. In regards to her occupations, ADL, most of the time she was performing these without, had some pain here and there. More was a motivation issue. Her sleep routine was not very good. She had a really hard time falling asleep. That's kind of when she would ruminate about the day or about any stressors that she may have had. So that was a big area to work on. Hydration and diet. She did pretty well keeping herself hydrated and had a pretty well balanced diet for an 8-year-old. And IADL chores tended to be really challenging. She was really not motivated. She reported more pain during these. Homework she actually did pretty well with because she enjoyed school. So, and she didn't have to do a lot of moving around. So sitting sedentary and doing homework was fun for her. Education wise, again, we talked about before, she attended school most of the time. There were periods where she missed a couple of days here and there. Socially, she tended to get really anxious around new people, peers, adults, all around. So that was a little bit stressful for her at times. In play and leisure, we talked about she loved reading. She could probably read all day long. She loved crafting, doing construction-based tasks like STEM building activities and things like that. And the assessments that I completed during the evaluation, we did obviously the FACES pain scale, the FDI, and the PEDS QL. Some OT goals. The ultimate goal was to increase her participation in all daily occupations. We really focused on including her home exercise program into her daily routine, adding calming strategies to her nighttime routine because that was really challenging for her, limiting her reading so she wouldn't stay up all night. We worked on her endurance so she wasn't fatigued by the end, and working on some of that interoception, like a modified version of that curriculum to work on being able to identify those emotions and body states to help with their self-regulation. We did some core work, some strength and endurance. We did some yoga, mindfulness. We did some desensitization on her lower extremities. So usually a towel or sometimes one of those vibrating head massagers were a good one to use too. So some interventions that we did, obviously education, had that strong therapeutic relationship that we built over the time, obstacle courses, building all kinds of crazy balance and strength-based obstacle courses, yoga again, using all those arts and crafts as throughout the session, magnet tiles, STEM construction types of tasks, board games and puzzles, really working her mind. She really liked that type of thing, so we used that. That was really motivating. Again, the desensitization, some therapy or stress ball, some of the interoception, mindfulness, and working on developing a really individualized home exercise program for her to continue because that carryover is really important, and making that a toolbox full of items that she could use. If her pain was really bad, she had a couple of fidgets she really liked, keeping them in one spot that she knew where they were. So if that pain kind of overrides, she could kind of work through it that way. So here's an example of a combined PT-OT home exercise program. So in the morning, we had her doing a minute of burpees. We had 2 30-second planks. We had her swimming, lying prone on our belly. We had a minute of squats, finding beads and therapy, using that head massager on her legs for 1 to 2 minutes for desensitization, and then a body check-in. How's her body, and not focusing on the pain piece. How are the other signals in her body? Is she hungry? Is she tired? Is she feeling excited about something? Those types of things. The evening, we had her do crab walks across the living room. We had her doing arm raises, stress ball squeezes, again, a body check-in, working on trying to calm herself down and be able to fall asleep eventually using those calming activities, not reading because she would stay up all night doing that. And then some meditation. So Zen Den is a really cool one from Cosmic Kids from Go Noodle that they do too. And that's our resource. These are our resources. And that's it. Thank you.
Thank you guys very much.
Yeah.
So if you have any questions, please feel free to either unmute yourself and ask, or you can type it into the chat as monitoring the chat.
See them? Maybe. Sure.
In the interim, I do actually have a question.
Sure.
So this great presentation, by the way.
Thank you.
This is very similar to plastic paint. Do you guys know of any literature that shows if kids have AMPS that they end up with
Yes.
plastic paint?
Yes, it's like a chronic, like we were saying in the prognosis, it really varied. Like a lot of the research that I was looking at showed short-term wise, they do get better. especially within 5 years. But if the child were to have like chronic pain in childhood, it was more likely they would also have chronic pain going into adulthood. Yep.
A second follow-up question to that is, if you intervene early and are able to get that under control as a kid, does it decrease the risk that you will have chronic pain later in life? And I guess for the healthcare system, and need fewer services later on down the road.
I mean, I don't know specific literature, but you would think if they're developing those coping skills, if they're developing that really good exercise routine, which is, what we're trying to get to, that they should be able to, if they can keep up with it, that should help in the long term. Now, is that always the case? Probably not. And now mental health can be a tricky thing at times, so that can play a role. But if they can keep to those routines, I would think long term it would make a difference. So we wouldn't have as many adults with pain because they would know how to handle it. Now you could have a flare and things like that, but if the flare is going on, at least you'd have the tools. You could go back to your toolbox and be like, oh, these are the things that helped before, maybe it will help again. So you don't have to necessarily go and get all of that medical help right away.
Yeah.
And I would think.
I would also say too, also learning from a young age, like as we discussed how exercise helps to modulate the pain, learning from a young age that movement and exercise is good and it's not something to be fearful of or avoided, I think would help that individual lifelong and then our healthcare system as a whole. Yes.
Mm-hmm.
But also in this specific case, I recall like mom genuinely thought that her daughter couldn't do any movement or shouldn't be moving. She thought it would make her pain worse. So
again,
lots of education.
Education is huge. Again, if they don't understand why we're doing what we're doing, they're not going to buy in, and then that's not going to help. So really taking that time to educate, showing the diagrams, explaining the whole pain cycle, how that works, why the movement and all of the other things that we're doing makes a difference, I think will help. But
That's setting up these paid food site services in the area. And I'll tag on to that question. I have a very similar question. Have you developed contacts and resources in the area to help with kids? I know adults, I have a very difficult time getting them on-site services necessary.
that's the same with us. We have only really seen a handful of patients with AMPS so far. We've had other experiences, other locations, and that mental health piece is always the hardest part. And it's not just any mental health provider. You really want to make sure that that person clicks and it's beneficial, because if it's not, then it's just one more service that is not helping. It's not going to make anything better. But yeah, I think globally, I mean, just in general, in the healthcare system, mental health services are really hard to find lately, especially for kids. I mean, the wait list is, years sometimes, and that's really frustrating and hard. So yeah, it's tricky, and that's something that we need to work on, building those connections and those relationships to make this program super duper successful.
Yeah. And
yeah, that'd be great.
And I will say, if it not only just making sure that they are seeking the correct psychological or mental health help that they need, we do try to make an effort to make sure that the child transitions to some sort of extracurricular or physical activity once discharged. So in this specific case, mom signed her up for Girls on the Run, which is a program in the community. Also, if the family's going through financial hardships, there's scholarships for that program. So she was able to run with age-matched peers, and then there were some, it's not only a running program, but there were built-in sessions where she learns about confidence and how to be a good friend and other values. So she was able to transition to some sort of an extracurricular activity and some social interactions too. Yeah.
Make sure you fill out the course evaluation and make sure you complete the course quiz so that you get credit for this CE or CME presentation. Professionals. Thank you very much, and we'll see you next month.